Chitra here, your mentor at StudyMEDIC and StudyMRCOG, and we are back with our back-to-back series to help you in your preparation for your Part 3 MRCOG exam. Today in this video, we are going to be seeing some stations that would appear in the module Management of Delivery. So this module is somewhat of an overlap between management of labor and delivery. The type of cases that you can expect here is anything about operative vaginal delivery, either obtaining a consent or teaching to a colleague, or teaching to, those would be the type of cases. Then a retained placenta, how would you do a manual removal of placenta, management of female genital mutilation, malpresentations and malpositions, like how would you deliver a breech, shoulder dystocia, cesarean section, normal and complex vaginal deliveries, mainly teaching stations, or it could even come in the form of a structured discussion. So today we are going to see the various variations that would come in breech delivery. Like it would come as a simulated patient task where you have a lady who is late in labor, she early in labor, diagnosed with a breech presentation, and you have to counsel her about the various management options for her. Or you have someone who is not in labor, she is at term but diagnosed with a breech, so what are the various options for her? Or you could have your junior who has come to you asking you about how to conduct a breech delivery. So let us see what are the various what would be the differences in your approach to these stations. So the first task here, it's a simulated patient task, and you have this lady who is a para 2, 36 weeks of pregnancy. She was seen by the midwife yesterday. The midwife has diagnosed a breech presentation and she has sent her to you for a consult. A scan has already been done, and it shows that there is a single live intrauterine pregnancy. It is a breech with extended legs. Placenta is fundal. Fetal cardiac activity is 150. Liquor is adequate. Fetal movements are active, and expected birth weight is in the 15th centile. So from this ultrasound report, immediately it should come to your mind that there are no contraindications as such to a vaginal breech delivery, except for the extended legs. You would want to know whether it is a footling or whether it is a flank breech. So here you have to talk to this lady. She is not in labor, remember that, and she is a multi, and she is at 36 weeks. So in the 2 minutes that you have of your reading time, you have to assimilate all this information in your mind, and the first thing that should come to your mind is that there are 3 options for her. The first is you can wait for her for another week till she becomes 37 weeks. Call her back for a consult again, because many of times we see that the breech has reverted to a cephalic presentation, so then you don't have to do anything for that. Or you could offer her an external cephalic version, or you could offer her a vaginal breech delivery. The fourth option is a CS. So all these things you have to keep in mind. Now, one thing you have to do, they have written that she is a para 2. They have not mentioned about her previous obstetric history. So that is one thing that you have to take in her information gathering, because if she is someone who has had a previous CS, then a vaginal breech delivery would definitely be contraindicated. But this previous CS, it is not contraindication for an ECV or external cephalic version. Okay. And the other thing that you have to keep in mind is that you have to ask her what are her fertility plans, what is the number of children that she plans to have in future, because if she refuses to have an external cephalic version, and she refuses a vaginal breech delivery, and she wants to go ahead with a CS, you have to tell her what the CS would mean for her in terms of future birth. Like she would If she wants to have more children in the future, then it would involve having a VBAC. Then the risks of the placenta being adherent, the risk of a low-lying placenta, and the immediate complications that would arise with the CS, namely hemorrhage, infection, the risks of anesthesia, and what it would mean for the baby, like an increased risk of stillbirth in future pregnancy. So all these things should flash before your mind in the 2 minutes, and then you can enter the cubicle and start your station. So like we said here in information gathering, it's not only what you would ask the lady, but all the information that is given to you in candidate instructions. So you have to understand the ultrasound report very well. Now remember here that a footling presentation is not a contraindication to an external cephalic version. You can still go ahead and do an external cephalic version. So in information gathering, ask her everything about this pregnancy, where any concerns are there, any comorbidities that she has, diabetes, hypertension. Don't forget to ask her about her previous obstetric history, any complications during that birth, comorbidities like medical, diabetes and hypertension, any previous surgeries on her abdomen, her family history, BMI, because a high BMI would make an external cephalic version a little bit more difficult. Now, habits, alcohol, smoking, and drugs, because if she wants to have a CS, then her smoking puts her at a high risk of anesthesia. Also, ask her about her mental status and what is the support at home. So, that would make your information gathering complete. Now, communication skills with patients, your introduction has to be very proper. Listen to what the lady has to say without interruption. But don't give her the impression that she's just going on talking. You have to practice what is called as active listening. Once she has done with whatever she has to say, go in, ask what further information you want to gather from her, and then explain to her all the options that she has. And at the end, you have to respect the decision of what the lady wants. Like, even though you want to do an ECV for her, but she says, no, I don't want to do an ECV. I will, and I'm not bothered if the baby remains in the breech position. I'm scared of a vaginal breech delivery. I would like to go ahead and do a CS, even though she wants to have more children in the future. So you have to respect her decisions. Okay. In the end, offer her patient information leaflets and ask her to come back for a consult after a week. Now, patient safety, all the usual points like allergies, what is her blood group, any reservations for blood transfusion, rule out any contraindications for vaginal breech delivery. Like I said, very important to find out what was her previous delivery like. If it was a previous CS, definitely a vaginal breech delivery this time is contraindicated. And also rule out any contraindications for an external cephalic version. There are very few contraindications, only like if she is in labor, if she's more than 4 centimeters dilated, if she has leaking membranes, or any contraindication that is there for a vaginal delivery, like she has a placenta previa, then definitely an ECV is contraindicated. One more thing you have to keep in mind is you want to know her rhesus status. If she is Rh negative and you are trying an external cephalic version, don't forget to give her an injection of immunoglobulin, even though she has had her antenatal immunoglobulin, because an ECV is a potential sensitizing event. Now, in applied clinical knowledge, you have to know all the options that we just mentioned about. She has 3 options: vaginal breech delivery, ECV, or a CS. And you have to talk about all the advantages and disadvantages of all these options. So you have to know that ECV can be done or should be tried after 37 weeks of pregnancy for a multi, 36 weeks for a primary. And there are chances of failure, like almost 1 in 2 would fail, but no problem, you can try it again the next time. Okay, and you have to explain to her what could be the consequences associated with an ECV, very rare chance of fetal heart disturbances, and that she might be needed for an emergency CS. And after external cephalic version has been done, you would monitor her fetal heart rate electronically. You also have to explain to her about vaginal breech delivery, the associated complications, and lastly LSCS if other options are not acceptable, and also talk to her about all the complications associated with a CS. So let us see what are the options available, what are the advantages and disadvantages of each option. So ECV, we saw that for multis, you will do it from 37 weeks of pregnancy. Success rate is about 50%. It reduces definitely the chances of a CS. But labor after an ECV, there is an increased chance of a CS and also an increased chance of operative vaginal deliveries. If you find that the woman is not able to tolerate the procedure or her abdominal walls are very tense, you can offer her tocolytics. The complications are very less. You will do electronic fetal monitoring after you have done an ECV, and make sure that you do this ECV in a place where there are facilities available for an emergency CS. It has to be performed by a trained practitioner. So these are the minimum things that you would talk to her, and also about giving her anti-D injections. Now coming to a planned CS. So there is a small reduction in perinatal mortality as opposed to a planned vaginal breech delivery. And a planned CS, it definitely avoids a stillbirth after 39 weeks. It will avoid all the intrapartum risks for the baby. It avoids the risk of a vaginal breech birth. To the mother, the immediate complications for the mother are there. More complications whenever it is an emergency CS. There are increased complications in future pregnancies, like the risk of VBAC, repeat CS, and adherent placenta. And there is a small increase in risk of stillbirth for subsequent babies. Now, a planned vaginal breech delivery. Here, it increases the risk of low Apgar scores, and there are serious short-term complications. Remember, long-term complications are not much. It doesn't increase the risk of long-term morbidity. There are least maternal complications whenever you have a successful vaginal delivery, but you need a skilled birth assistant. And remember, for a vaginal breech delivery, there is no role of induction of labor. Augmentation can be offered. If you are offering regional anesthesia, it can increase the risk of intervention. And it has been found that if you offer electronic fetal monitoring, it improves the fetal outcome. But remember, when you're doing a planned vaginal breech delivery, the birth should always take place in a hospital with facilities for emergency CS. So these are the minimum requirements that you would need for a clear pass or a global pass, that you would say. These are the minimal things that you have to talk about. The guideline talks something called as moxibustion, which is a Chinese herb and which allegedly it increases the fetal movements, and there is no need to do an external cephalic version. Because of the increased fetal movements, the baby itself turns into a cephalic presentation. I'm talking about this because it is given in the guideline. It is given in Green Top guideline. So these are the role player instructions. What I would suggest to you is that you open up the page on candidate instructions, you stop the video, rehearse the station in your mind, then have a look at all the domains that I have mentioned about. Mark yourself on what you have said, what you have missed out on, okay, and then listen to the complete video. Now, another task that you have, a variation here, is about this P2 in early labor. The midwife who saw her, she has diagnosed a breech presentation and she has sent to you for a consult. Now remember, this lady is in labor. So what is the difference between these two? So remember here that in information gathering, this lady is in early labor. You will gather all the information. Before that, ask her how much in pain is she. Does she need any pain relief? Does she have leaking? Does she have bleeding? How about the fetal movements? Okay, is anybody else present with her who she would like to be during the consultation, because you're going to give her a lot of information. Now remember, if she is less than 4 centimeters dilated, if there is no leaking, if there is no bleeding, if the ultrasound shows that the baby is average size, you can still go ahead and offer her an ECV. Or she has the other options of having a planned vaginal breech delivery, or she can also opt for a CS. So all this you have to tell her in a very non-judgmental manner. Give her the patient information leaflets, give her some time to think, and then you can come back to her and ask her what is her decision. Now remember, any patient in labor, if she shows any signs of getting a contraction, if she sees that she's too much in pain, just wait for about 20 to 30 seconds till the contraction has passed away. Then you can talk to her. So that would show that you are not running on your own agenda and you are paying attention to what is happening to the role player. So basically in these two stations, there is not much of difference in the amount of applied clinical knowledge. It is only your information gathering and communication skills that are going to be marked a little bit differently. Okay. So the options available are essentially the same, either an ECV if she is less than, remember, less than 4 centimeters, no leaking membranes, no bleeding, no contraindications for a vaginal birth. Okay, all these are present, you can offer her an ECV. Okay. Now the third type of station that you could have is something like a teaching station. So you are the ST5 in the labor room suite and you are about to meet Sarah. She is your newly joined ST1 and she has requested a session on vaginal breech delivery. So you are supposed to talk to her, find out what are her expectations, and you have to teach her how to conduct a vaginal breech delivery. Now remember, whenever it is a teaching station, information gathering would be about two parts. For the STI, you have to rule out any bullying and undermining, and for the patient, whatever information gathering, it has to be there to rule out any contraindications to a vaginal breech delivery. Keep one thing in mind that teaching about a vaginal breech delivery, it's a lengthy kind of station and you would really not be having time to complete the station. So usually in these kind of stations, there would not be a hidden agenda. But you should not ignore that fact. Whenever you are doing a teaching station, remember that you have to rule out bullying and undermining and make sure that your ST1 is working in a safe environment. It would take minimum like 20 to 30 seconds to make her feel at home, make sure that her working environment is safe, and then go ahead with the station. And that would also give you a lot of points in your information gathering and in patient safety. Okay. Now, communication skills with your colleague, you have to ensure safety of your ST1. You have to maintain an atmosphere that is conducive for teaching and learning. Involve your ST1 actively. So if any props have been kept there, that means there is a mannequin and there is a baby that is kept there, make sure that you are involving your ST1. Let her hold the mannequin, let her hold the baby. Once you have demonstrated the maneuvers, let her do the maneuvers herself so that you are actively involving your ST1 in the station. And remember, you are talking to a doctor, so it is not perfectly fine. I mean, you should be using medical terms and you should not be using layman's terms. Now, patient safety, again, make sure that the ST1 is safe at work, and for the patient, there are no contraindications to a vaginal breech birth. Now, applied clinical knowledge, you have to talk about the types of breech. Don't go into too much of detail because in 10 minutes, you really don't have time to talk everything about that. You can just talk about the three types: a footling breech, then you have a breech with extended legs, or you have a frank breech. Now, the methods that you have are breech extraction, spontaneous breech delivery, or an assisted breech delivery. So breech extraction is something that is done only in emergency procedures. Spontaneous breech delivery is usually not advocated. What we normally do most of the times is an assisted breech delivery. So that is what you are going to talk about. And at the end of the session, make sure that you get a feedback from your junior. And if you are not able to complete the session, you can always say that we can have another teaching session a few days later on, and I could also give you some links for reading or some links to watch videos. Okay, so that would complete your station. Now, what exactly are you supposed to talk about an assisted breech delivery? So, first of all, you have to tell her or him or her, whoever is your junior, that a breech delivery, it should be conducted in a hospital setting. The person who is going to conduct the breech delivery has to be competent. There has to be like you have to be in a hospital, and there should be facilities for conducting an emergency CS. So these are the minimum requirements. Now, assisted breech delivery means it is usually a hands-off technique. So you have a senior obstetrician who is experienced in conducting a vaginal delivery, vaginal breech delivery. Remember, the woman, she would be on continuous electronic fetal monitoring, and once you're sure that she is fully dilated, the maternal bladder and the rectum, it should be emptied, and you have to consider the need for an episiotomy if needed. Active pushing is usually delayed until the breech is distending the introitus. Once you see that the breech is climbing the perineum, at this time the woman, she should be placed in the dorsal lithotomy position. And remember to talk about hand hygiene. You should put on a pair of sterile gloves. The neonatal team has to be alerted, and your burning trolley should also be ready. There should be facilities for neonatal resuscitation. So for delivery of the lower limbs and the trunk, maternal effort should expel the breech spontaneously up to the level of the umbilicus without traction, and make sure that the breech, the sacrum, is in the anterior position. So if you think that the back is turning posterior, without giving undue traction, gently rotate the breech so that the sacrum remains anterior. Okay, and if the fetal legs are extended at this point of time, you can deliver the fetal legs by applying pressure with 2 fingers in the popliteal fossa so that you can flex the leg, grab the foot of the baby and bring it down. Then let the baby hang by its own weight. You can cover the baby in warm sterile cloth. And once the inferior angle of the scapula is visible, the arms can be hooked down by inserting a finger in the elbow and flexing the arms across the chest. Now, if the fetal arms are extended, or if you have a nuchal arm, so what is a nuchal arm? Means when one of the arm is extended behind the fetal neck. So it is something like this. So that is called as a nuchal arm. So for this, you can do the Lovset maneuver. So what is the Lovset maneuver? You take advantage of the inclination of the pelvis. We know that posteriorly, the posterior shoulder, it is always at a lower level than the anterior shoulder. So you rotate the breech and make sure that the posterior shoulder comes anterior. When the posterior shoulder comes anterior, because it is at a lower level, it slips under the symphysis pubis, and then you can deliver that arm. Then rotate the breech back again through 180 degrees so that now the shoulder which was posterior, it becomes anterior, and then you can deliver both the arms. So that is basically what is called as the Lovset maneuver. Then you have to talk about delivery of the aftercoming head. So previously we talked about Mauritius-Smellie-Wet method or Burns-Marshall, or if in some circumstances you have to apply forceps. So remember, these days Burns-Marshall is not spoken about because it is found that it can cause injury to the fetal spine. So please don't talk about Burns-Marshall method. You will only talk about Mauritius-Smellie-Wet method. And in this also remember that you will not put your fingers in the mouth of the fetus. The index finger and the ring finger, they are kept on the malar prominences. The middle finger is kept on the nose. So your non-dominant hand, on your non-dominant hand, the breech will be resting, and the other dominant, with the dominant hand, the two your index finger and the ring finger, it will be placed on the two shoulders, and with the middle finger you will flex the fetal head, and with a maternal contraction in a controlled manner you will deliver the head of the baby, and at the same time somebody can give suprapubic pressure to promote flexion of the fetal head. If you are not able to deliver the fetal head, you can apply forceps. So specialized type of forceps called as Piper forceps are available, or if those are not available, you could use Keelan forceps. So when do you apply forceps? So if the head has not delivered within 2 to 3 minutes of attempting the Marshos-Millivet maneuver, you can apply forceps. So for forceps, what happens is your assistant will lift up the baby and the forceps are applied from below. Okay, so please remember that. And you can consider the use of an episiotomy if necessary at this stage, and it has not been given. Now for management of third stage of labor, it should be managed in the usual manner. You have to assess the perineum for any kinds of trauma because you would be doing a lot of maneuvers there. And then once the baby has been delivered, clamp and cut the cord and hand over the baby to the neonatal team for assessment. Okay, so this is all about assisted breech delivery. Now breech extraction, basically it describes an emergency procedure that is undertaken in order to expedite birth when in a breech presentation. It is very rarely done, and it is done only like if there is severe fetal distress during the second stage of labor with a breech presentation. And breech extraction, remember, it is usually done under general anesthesia, or whenever you have a twin presentation, the second twin is in breech presentation, or it is a transverse lie and you have done an internal podalic version, then in those cases internal podalic version is always followed by a breech extraction. Okay, so that is all that I had to say to you. I hope I have made the topic of breech delivery a little bit easier for all of you. And yeah, I know exams are around the corner. So good luck to all of you. Go for the exam with a very clear and a calm mind, and you will rock the exams. Thank you once again for watching the video, and good luck to you for your exams. Bye bye and take care.